obesity should be considered an epidemic, and the government should, the government. It's like, well, what do you mean by the government? But anyway, not to rabbit trail too much. I guess that's a good segue into how preventive medicine interacts with family medicine and obesity medicine. People are pretty familiar, at least the listeners to this podcast are probably familiar with the obesity epidemic and how the CDC does consider it an epidemic. Often people in the health optimization community say obesity should be treated as a disease, and it actually is considered a disease. And obesity should be considered an epidemic, and the government should, the government. It's like, well, what do you mean by the government? But anyway, not to rabbit trail too much. But the obesity medicine, clinician academic group is exploding. When I was board certified 2.5 or 3 years ago, I believe there was only 3,000 or 4,000 total obesity medicine physicians. And now that number has doubled, even in just a couple of short years. A lot of what I see as preventive medicine overlaps directly with that.
Absolutely. I think so. I think all three of those specialties, preventive medicine, family medicine, and obesity medicine, have a lot of overlap. I would say the main differences between preventive medicine and family medicine is, I think, a more rigorous clinical training. Preventive medicine, it focuses on a lot of that, both pediatric and adult populations, and is a primary care specialty, but also incorporates a lot of population health and rigorous statistical training that I don't think you necessarily get in a traditional family medicine training, because you're so focused on just that clinical care. And so I think that's probably the main difference between those two. Also with a bias towards prevention on the preventive medicine side. So obesity medicine is a subspecialty. So after you get a primary specialty in preventive medicine or family medicine or internal medicine, you can subspecialty in obesity medicine. And that gives you further training in how to treat obesity. I think considering obesity as a disease is super important. I think there's been some hesitation in that for a while, because obesity is not the primary cause of death in anybody, but it's associated with many of the leading causes of death. I think in the CDC top 10 causes of death, obesity is highly associated with incidence and worse outcomes. So more likely to die from these diseases in like 6 or 7 of those top 10 diseases. Mm-hmm. So it's really, really impactful. I am not board certified in obesity medicine, but where I did my training at Johns Hopkins, we staffed an obesity medicine clinic. I guess I'm curious what getting the subspecialty in obesity medicine provides you, more so than just a primary specialty and feeling comfortable with prescribing those medications.
Yeah. A specialty in obesity medicine is pretty similar to a specialty in family medicine. You get out of it what you put into it. Here's a hot take is there's a concept known as a delta, and I think this is in several sports. I believe it's in rock climbing. So different people have a different delta within the same sport. So in the example of rock climbing, and I don't currently rock climb or boulder much right now, but I used to quite often, and a lot of my colleagues do. It seems to be something that a lot of doctors actually share in common. Their love of rock climbing is very, very random. Not sure how close the correlation is, but anyway, different people have a different delta, a way of going about things. And the specific hot take is wide, like mile wide, inch deep specialties that have a large scope of practice, a potentially very large scope of practice, like obesity medicine, like family medicine, like preventive medicine. The potential to set a very high delta or a high starting weight, maybe our audience will appreciate like weightlifting or powerlifting. Different people start at a different standard and do things a different way. They choose different grips. There's different ways of doing things. But in obesity medicine, the specialty itself is actually quite easy to get as long as you put into it just enough to get through the CME and pass the exam. There is obesity medicine programs as well, which are likely of very high quality. I haven't done a specific program itself, just the board certification, but you only get out of it what you put into it. This is pretty well known in family medicine, where you have, on average, the least qualified and the lowest test scores going into that specialty, despite it being theoretically the highest amount of delta that you can put into it.
Yeah, that makes a lot of sense.
Preventive medicine is kind of the same way. I could see a lot of other preventive medicine physicians really focusing on the informatics and statistics side of things. And clinical medicine is like any other profession. If you don't use it, you lose it.
Exactly. Yeah, your skills atrophy. Yeah, for example, where I did my training at Hopkins, it was very focused on population health and the clinical aspect of preventive medicine.
Mm-hmm.
And my training was very focused on this obesity training. And where I'm practicing now at a large health system in California, it's much more focused on the lifestyle medicine aspect. And so the training is quite a bit different between those two.
Yeah.
I guess I'm wondering, if I was a patient with obesity, should I seek out a physician with obesity certification, or do you think going to your primary care doctor would be sufficient?
If you do no research into who to go to, it's kind of like thinking about, should I go to a mechanic that specializes in carburetors or just a random mechanic? It's possible that the random mechanic can fix the carburetor, or I guess most cars have an EFI now, but you have a better likelihood of going to a mechanic that at least says something about carburetor in the website. So there is physicians that do treat obesity well that are not board certified, but if that's available in your area, you might as well seek that out. I always tell people it's okay. It's not doctor shopping if you're reading different biographies of doctors on their websites and you think he or she might be a good fit, he or she might be a terrible fit, and then trying a couple that would be a good fit and then finding whichever one is the best fit for you.
That makes sense. And in discussing with my colleagues, I guess one thing I've noticed is that the ones who are more generalist, who aren't obesity certified, they can attack some of the kind of first line and second line treatments. They're pretty familiar with the GLP-1 agonist and maybe Contrave, but they're less familiar with some of the other more specific medications like phentermine or orlistat, and then certainly they don't feel comfortable prescribing off-label medications, where it seems like the obesity medicine trained physicians feel very comfortable prescribing unique off-label medications.
Yeah, they're also less likely to work at an interdisciplinary clinic that has a dietitian or a personal trainer, less likely to get like a deep dive into their sleep in addition to their diet and exercise. So those are some pros and cons. Certainly, the more severe the pathology, almost all pathologies are on a continuum or a spectrum, the more it would be reasonable to seek out an expert in that area.
That makes sense. And the majority of the high quality evidence that I've seen pairs medication with lifestyle changes. So you need a high quality multidisciplinary team to improve your nutrition and your physical activity and your behavior, which are all three as important, maybe more important than that medication aspect. And usually in primary care, they might not have the resources or the time to provide that.
Yep.